Hi everyone, thank you Anita for the introduction. So it's lovely to be here presenting part of my PhD, which its focus is on privacy needs of adolescent patients at palliative care and patients unit. So it's part of my PhD, which is undertaken at University of Sydney. So starting with giving you a summary of what is in the context, most pediatric hospices are designed to accommodate a broad range group from infants to adolescents. So this broad approach kind of overlooks the distinct or special developmental and emotional needs that this age group are in need of. So in a setting that adolescents face kind of the most challenging time of their life, a lack of privacy and control for them can even make it harder to feel respected and dignified. Oh, sorry. Adolescence is a time of rapid changes, physically, emotionally, and socially. So it's a time that they kind of build their own identity. They seek for their individual autonomy and control over their surroundings. But for adolescent patients who are receiving end-of-life care or palliative care, that independence can kind of taken away because of the medical procedure, because of frequent monitoring and constant presence of staff. They might miss their everyday moment of life, like catching up with friends, spending time with their partners, or having some time by themselves alone. So current research show us that most of our current literature study that we have studied mostly shows that the hospice architecture often prioritizes on clinical efficiency and operational flow. The assumption is that if the kind of standard and logistic needs of care are met, then the emotional well-being of them naturally will follow. But adolescents' developmental needs are completely different to other age group, and the research shows us that there are limited studies and research on this age group compared to other age groups. And the architects mostly designed with having a general idea or imagine this age group or other age group in hospice architecture or palliative care architecture. They have kind of abstract ideas about their body and image. So we need to study this. We need to understand how they are different and how their needs might be different. So my research asks a simple but really important question: how does architectural design can balance delivery with privacy and autonomy for adolescents? So it's a kind of combined approach here. We start by studying literature. So mostly when I started gathering the literature, I found that most of them has been in kind of like published in public health, kind of publishing medicine study, not architecture itself. And so in line with that, as we see that there is limited research in this area, we continue our study by studying or analyzing the hospice environment, their architectural design, go deeper to their design. We use hospices over hospitals because hospice are the best design practice that show how the palliative care approaches. And in line with that, we have interviews with people who work with these people, like staff who work closely with young patients in palliative care settings, like doctors, nurses, psychologists, social workers. And also we have interviewed with architects who were involved in design of hospices across Australia. So from this slide, I'm showing what I found, focusing on the privacy needs. So the first thing I want to share is about privacy and exposure in bedrooms. So across all of the facilities that I studied, I found that most of them has considered to have a single patient room. Some of them were like en-suite bedrooms. Some of them were bedrooms with shared bathrooms. It seems like that having a single bedroom is equivalent to having privacy for patients. But when we go deeper and look at the design of these rooms, we can see the bed is positioned at the center of the room, always visible from the corridor. And sometimes we can see camera installed on the bedrooms or glazed panel on the doors. So how can a teenager staying in this bedroom feel that they have privacy when they are under such observation all the time? We heard from kind of our interviews with a pediatric manager who told us that they hear from adolescent patients that they feel like the hospice bedroom look like the hospital bedroom for them, reminding their illnesses all the time. So we talk about the monitoring. It's good to focus more on this part. So interviews with the staff shows us that they stress the importance of visibility for safety and controlling the patients, and it's completely understandable. But what was interesting was that when we have this discussion about this, they mentioned that having some features like glazed panels on the door or cameras or windows, they call it like a positive feature in the design that help them to not disturb patients without entering the room. So they could check in without entering the room. So how this might possible for a person who reside in the bedroom to feel that they are always under observation, under constant observation, how they feel about their own privacy. We can see the cameras here. The other topic I want to discuss about the privacy is about age-appropriate design. So most of the hospices in Australia, as I mentioned, I think before, accommodate a wide range group, younger children and adolescents together. We only have just one Adolescent Hospice in Australia, which is located in Sydney and is mainly Adolescent Hospice. So when we have these both age group in the same place, we need to think how they might be different. So our interviews shows that how staff find this. They said, for example, adolescent patients are in need of more alone time. They don't want to talk with anybody for sometimes, for not being connection with staff, or even their parents. For example, younger children, as staff told us, always want their parents to be around them, but about adolescent patients is different. And they might even don't like their parents to be around them. They might want their friends, siblings, or their partner to be around them. And how the architecture design of hospices kind of accommodate this. If we look deeper, we can see that they consider some differences between younger patients and older ones, like having teenager playing area, teenager activity area, a specific area for them. But it's like more rely on cosmetic differences, like different colors or furniture size. For example, in this hospice, if we look at the zoning or layout of bedroom, we can see that the older patients, like adolescents group, room are clustered together here, and this is the rooms of younger patients. Both of them kind of are positioned in one overall patient zone, and so they use same corridors. So if we stay in this environment, we might not feel that differences or distinctions there. So the other studies also shows these differences. However, they are not specifically in hospice environment. For example, one of the studies shows that how adolescent patients feel nervous to be surrounded by younger children, or families' frustration about not finding a specific design teenager area for their child. And we discussed this with architects we have interviewed, and they acknowledge the importance of this, but they said it's not always realistic to have, for example, different zone for younger patients and older ones. They said because of the kind of a small facility that they have to design, it might not be practical to do this. So instead, they suggest differences like, as I mentioned, different finishes, different colors, furnitures, like this one. So go to another topic. I think it's the last one. It's about autonomy and independence for adolescent patients. So also the interviews show us how teenagers with life-limiting illness still have sexual needs, they still have desire and relationship. And so, for example, one of the medical staff participants, I'm quoting, said, I think their sexual needs become quite big in their mind. They want to make the most of their life they have got. Or the psychologist said that it's quite important or significant for adolescents, and it's really important for them to have those kind of intimacy in their life. Or their parents, as again, then one of the nurses told me that some parents came to them. They said to them that and they want their child have sex before they die. So how about the architecture design? We have single bedrooms, but with single beds, not that quite big or spacious that we could bring another bed inside, constant monitoring, constant visiting them. And also, the interview told some participants told us there are some policies and institutional cultures that avoid some of those intimacy happen in the hospice environment. So I think this is really important, as I think the participants also acknowledge they hear a lot about from adolescents that they want bigger size bed, they want to bring their partners inside. So I think this is really important to think about it more. So the last part of my speech, I want to say that I think in total, adolescents in palliative care are still too often overlooked, and we can see easily in research and also I think in practice. And the built-in environment plays a powerful role here. It's not just a backdrop to care, but a tool for empowerment, shaping how young people experience autonomy and identity. I think we need to design not only for clinical functions, but for emotional well-being and a sense of self. Because for adolescents at the end of life, feeling seen, respected, and in control of their space can be just as important as the care itself. And just the ending notes, these are my publications till now from this stage of my study. And yeah, thank you.